So is Erin muted?
Erin is currently muted. She can hear you, she cannot talk to us.
Okay.
So you guys are ready to go?
So Erin, I understand that you're muted, but girl, it's you and me. That's who's on this.
Doing the recording.
So, and we're going to do a recording. So I'm going to walk you through this. What I don't know is if she was on the prior Know the 10 Signs one, because that, can we unmute her? Because I'd like to know if she was. It'll change. Erin? Erin, are you there?
She may have to type her answer.
Erin, you must not have a microphone. Will you answer us through chat, please?
So go ahead.
Just ask if she has been on any Know the 10 Signs presentations.
Yeah. And
I don't have a key.
Yeah, she can hear us.
She can hear us, and she'll type in just a
Oh, okay.
Well, she should be able to. Erin, are you there? How about the same thing I did?
I'm trying to send her a message.
So she's not attentive. That's what this sign here means. So she may not be at her desk.
Oh, it went away. She's there. We started just a couple seconds.
Erin, are you there?
Oh.
It's coming back on.
Yeah, so if you want, I could type her a message if you can.
Yeah, I
Okay.
want to know if she's been at any of the other Know the 10 Signs courses.
Well, and if she asks if she can hear us too.
Because it might seem kind of silly to go through the same information.
And I would say she hasn't been, and that's why she signed up.
But that's
I need somebody to click send.
Oh, here we go. Here we go.
Yeah.
Yes, I'm here. If it is Erin Grace here. Yes, yes, Erin, yes, it is. So you can hear us. So
The keyboard is weird.
okay, perfect. And have you
Yes, I can hear you.
have you attended a Know the 10 Signs training at all?
I've heard the local association person speak about it. Well, that would have been me, probably. Was that Susan Callison that you heard? Or was it me, Linda Brown? I don't know that much matters, but I'm trying to figure out.
And but you do need to do this in the respect of
Other people.
because
Okay.
this will be the training that goes on
Okay.
the portal for others to do.
No, Linda Brown recently in Des Moines at boot camp.
Oh, okay.
Okay. So that was so you heard a little bit about it. So we're gonna, I'm gonna recognize that I don't want to bore you to tears with things you've already heard. So we'll kind of go through this again and spend a little bit more time on communication. It's being recorded, Erin, so I need to kind of go through all of this.
Go ahead, Erin.
See, how do we?
So now you can advance it now.
Okay, so these are the objectives of what we're going to try to achieve today, and it's be able to identify the 10 warning signs, to cite some common communication considerations, and to cite some common support needs for both the person with dementia and the caregiver. Dementia is a general term for decline in mental ability that is severe enough to interfere with daily life. The key to this is that it interferes with daily life. And I'm going to talk about Alzheimer's disease particularly. It is brain failure. It's irreversible. It's progressive brain disease that slowly destroys memory and thinking skills. Dementia is the broader term. It covers all kinds of disease processes that are neurological in their origin. Alzheimer's accounts for 60 to 80% of all dementia, so you'll hear people refer to them interchangeably, but dementia is the broader category. Alzheimer's disease is brain failure, with the common sign being primarily memory and thinking skills. There are reversible forms of dementia, and it's important that we highlight these because it's the reason why people should go to the doctor when they see early signs. Those reversible forms are infection, medication, and medications can cause challenges. Medication interactions can cause reversible dementia. Dehydration, malnutrition, vitamin deficiencies, and depression can all give signs of dementia. What's more commonly thought about when it comes to dementia are the irreversible forms, and that's Alzheimer's disease, vascular dementia, which is related to strokes, Parkinson's disease sometimes, not all Parkinson's disease has a dementia component, Lewy body disease, frontal lobe, and you can see the others here, Huntington disease, head trauma, and alcoholism. A lot of people don't go see their physician because they are concerned, but we would challenge you in your role when you start seeing some of these signs to encourage people to go to the doctor in the event other things are going on that are causing dementia that can be corrected. Here's some basic dementia statistics. We've talked about Alzheimer's disease being 60 to 80% of all cases. It's more women's disease than it is a men's for a couple of reasons. Typically women live longer than men, and because it's a disease associated with age, women are affected more. Women are also the primary caregivers in many cases. It's the 6th leading cause of death in the United States. I would also say above the top 10 leading causes of death, it is the only disease for which there is no treatment, prevention, or cure. It's a disease related to age of Americans only, or of individuals over age 65, 1 in 9 has Alzheimer's disease. That's about 11%. Nearly half of people age 85 and older have the disease. Most people, the range of survival with Alzheimer's disease is 2 to 20 years, with the average being 8 years. And on average, the majority of people with Alzheimer's spend most of their time in the severe stage, which is what we typically think of when we think of a person with dementia. So who's at risk for Alzheimer's disease? I always say if you got a brain, you're at risk. And so we're all at risk, but the common risk factors are primarily age, family history. If you have health conditions that affect your vascular system, your circulation, that affect your heart, then you're at risk, and head injury. So family history, this is not a genetic disease. You can hear people talk about it. Only 5% of the population with Alzheimer's has a genetic component. It's incredibly rare. We are studying it, but there will be familial trends. The one that we talk most about is the heart-head connection, because it's something we can do something about. If we've got high blood pressure, heart disease, if we're at risk for stroke and we're not managing that, we have high cholesterol. Those are all put you at risk for dementia, primarily because the brain's energy comes from good blood flow. And if your heart isn't working well, or if you have a disease like diabetes that messes with the way your blood vessels function, then your brain is at risk for not getting the necessary nutrients that it needs to thrive. And then we all know about head injury, the traumatic brain injuries, Some of those are being experienced by our military folks, and then in the NFL, the Football League, the CTE is all related to dementia. So those are the risk factors. This slide just really kind of points out the higher degree of incidence among women than men, and you see that it goes up with age primarily because women live longer than men. Here's a slide that kind of shows you what happens to the brain. The slide on the brain slice on the left is a normal brain. The squares kind of point out the language centers and the memory centers. They're fully intact. A person with Alzheimer's disease, their brain literally shrinks. The white and gray matter deteriorate, and it starts primarily in the memory centers and it moves to the language centers. That's why communication becomes such an issue. So Alzheimer's disease, a lot of people just think it's confusion, you're not trying hard enough. It really is pathology of the brain that prevents the brain from functioning well. This is a scan that shows, a PET scan that shows glucose uptake, and glucose is energy for brain cells. On the right-hand side, it's a normal brain. All of the colors of red and yellow and green show active glucose sugar metabolism. So this brain is working at a lickety-split. On the right-hand side, this is late-stage Alzheimer's disease brain, and you'll see that there's very little tissue left that's functioning. And that's why when you see folks in late stage, they are unable to do much. Here's an interesting comparison. On the left-hand side is the late Alzheimer's brain, and on the right-hand side, it's an infant's brain. And so when you think about a person with Alzheimer's in the late stage and you're wondering about their functioning capability, you need to be thinking of the functioning capability of an infant, and you'll be pretty close to what they're capable of being able to do. Here we see really the graph of how Alzheimer's disease happens. The yellow line is healthy aging. There is some normal age-related memory loss. It is not near to the extent of what Alzheimer's disease has. And so if you look at the line that where it starts going into blue, this is where Alzheimer's disease, we believe, happens 10 to 20 years before symptoms start. Once you start hitting symptoms, mild cognitive impairment, which means that there's something not quite right, but you're not quite sure what it is. You're still able to do a lot of things, but you're noticing that your brain's not functioning the way it used to. As soon as mild cognitive impairment starts and you start getting into the cognitive decline associated with Alzheimer's disease, it goes very quickly and proceeds to death. Now, what it's important to point out is not everybody with mild cognitive impairment goes on to develop dementia and/or Alzheimer's disease. But anybody with Alzheimer's disease or other forms of dementia have experienced the mild cognitive impairment. Why some people with mild cognitive impairment go on to develop Alzheimer's disease and others do not, nobody really knows. So Iowa statistics, the percentage change we experience, we're looking at a tripling of the prevalence of Alzheimer's disease or the incidence in the next 10 years. And so by 2020, we are expecting to see a 6% increase, and in 5 years, that is supposed to be an 18% increase. We all talk about the silver tsunami, and that's what we're talking about, the high incidence of Alzheimer's disease that will be hitting the baby boomers, and we are ill-prepared to deal with that. If you take a look at the number of people aged 65 and older with Alzheimer's disease by age, you'll see that it's increasing in Iowa. We believe right now we have about, in 2016, we have 63,000 people in Iowa who have Alzheimer's disease. And you can see what those numbers look like, 66,000 by 2020 and 73,000 by 2025. Why is this important? We do not have the capacity to provide the health care for people that need the support from Alzheimer's disease in this state. We're already struggling with direct care workforce and having enough people to provide the care. This is going to be falling predominantly on caregivers. If you take a look at the cost of dementia caregivers and the cost of caregiving, right now we believe we have about 135,000 caregivers in the state of Iowa supporting 63,000 people with Alzheimer's disease, a little over a 2-to-1 ratio. They provide over $1.8 million, They provide $1.8 billion worth of healthcare costs that aren't having to be absorbed by the healthcare system. But what we also know is that caregivers of people with dementia have higher healthcare costs on their own. And it's because of the stress related with this type of care. So caregivers who are caring for a loved one with cancer or with heart disease do not experience the same level of stress that caregivers with dementia experience. Most caregivers of people with dementia will tell you that their biggest concern is that their health will deteriorate before their loved one with dementia passes away, and they will not be able to care for them. And then those people really have no other option but to go into long-term care. There are some drugs. You'll hear about some drugs for Alzheimer's disease. Please note that these do not treat the disease. They treat the symptoms of the disease, and it's essentially vitamins for the brain. And so you'll see some common ones. You'll hear about Aricept, Exelon. The big one is Namenda. Namenda and Aricept have combined to create a brand new drug, slow release. It relieves people of taking multiple pills. It also happens that both of those drugs just went generic this year. By combining them into one pill, they go back to a preferred non-generic status, and we know the implications of that for the drug companies. So if your folks are quite capable of swallowing pills, the most economic way is to take these drugs separately. But again, these drugs do not treat Alzheimer's disease. They simply boost neuron activity and help with memory function. It's believed that it only gives a small boost. Nobody really believes that they are effective for a very long period of time, but the medical community is reluctant to remove them for fear that there will be some memory decline. Early diagnosis is vital. We've talked about why that's important. It's because you can identify and treat the reversible causes. The medications, the Namenda, the Aricept, the Exelon, are believed to be more effective in the early stages to boost memory. But the real reason is it offers the greatest dignity to those people with dementia and their caregivers. They can begin planning for the future, making financial plans, making decisions about how they see their life playing out, and they want to have happen while they have a voice and can participate in those decisions. So we're going to talk a little bit about Know the 10 Signs. We've had some discussions, and I have some handouts that we will scan in for you. And we've talked a little bit about these in a number of ways, but we're going to go through them really quick. Memory changes, and these, I will tell you that these signs are in no particular order. They can happen at any time, in any order, in any degree. It only takes one to flag a person that there may be challenges. So you don't need 3 out of 10 or 2 out of 10. You need 1. Memory is the most common one associated with Alzheimer's disease. That is not true of the other dementias. You will see different changes in frontal temporal lobe, Lewy body disease, and vascular disease. But memory is one of the common signs, and it has to disrupt daily life. We often talk about it's not that you've lost your keys and then you're able to retrace your footsteps and find them. It's that you can't find them and you don't even remember when you last used them. So that would disrupt your daily life. Challenges in planning and solving problems. Alzheimer's disease, frontal temporal lobe, other dementias affect your executive function, the ability to critical think through challenges and be able to plan and solve problems. It causes difficulty in doing familiar tasks. I just got off the phone with a woman this morning. Her husband has gotten up every morning and fixed coffee all of his life. He has Alzheimer's disease. It's give and take on any given day whether he'll remember how to do the coffee or not. And so it's something he's done for all of his life, and on more times than not, he doesn't remember how to do coffee. Confusion with time or place. A lot of folks with dementia will leave their home and they won't know how to get back because they can't get oriented to their time and place. That has everything to do with trouble understanding visual images, spatial relationships. Is my house next to the greenhouse? They can't remember that kind of thing. They can't figure it out. The other thing, visual images, they'll misconstrue a rug on the floor for a hole in the floor. You'll see them try to walk over it. So you may see all kinds of these complications. Other problems, and you'll see a lot of this, problems with words and speaking and writing. These folks just forget basic language skills, and when we went back to see the slide of the brain and how it affects the language center, you can begin to understand. They misplace things. They lose their ability to retrace steps. They have decreased or poor judgment, and primarily from all of the other things that happened before. As a result of these things, they withdraw from work and social activities. Nobody wants to be found out. And then there's some change in mood and personality. Not all people with Alzheimer's disease become behavioral challenges. And I just spoke to a Medicaid managed care organization who believed that behavioral challenge were an eventuality of Alzheimer's disease, and that is not correct. However, there are changes in mood and personality, and most commonly associated with some of the other dementias. Frontal temporal lobe, classic for mood and personality changes. Why do we worry about this, and why are we talking to you about it? Because 70% of people with dementia live at home. Of those who live in long-term care, 75% of them have dementia. But most people who have dementia are living at home. Some of them are living home alone. And you can only imagine the challenges that they experience when they don't have somebody with them to support their day-to-day living. The effects of dementia, they have a lot of effects on their thinking skills. It affects various parts of the brain to different degrees. And like I said before, the symptoms occur in no particular order. So dementia affects memory. It affects motor skills, language, attention span, their perceptions, their abstract thinking, and their judgment. And this we're going to talk a little bit about how this plays out. So if it's memory, the short-term memory is affected first. Eventually it will be long-term memory, but that is the one that is most preserved. So people won't remember what you just told them 5 minutes ago. You're on the phone, you're getting an assessment. They may not remember what's going on in their lives or what just happened or what their address is, but they will remember some of their fondest memories from their childhood. Doesn't seem to make sense, but it's important that you know that. As a result, it's easy for them to lose their sense of identity. They'll get very confused, their world closes in around them very quickly. Education becomes difficult. So if you're producing a plan, an options plan for them, and you're going to teach them what they need to do, know that probably 5 or 10 minutes from now they will not remember a thing you said. As a result, compliance to that plan becomes very difficult. So anything we try to do with them in the immediate and then expect them to remember will be very difficult. So how do we compensate for that? We give them constant reminders. What is it that they do next? We simplify all tasks. We simplify our sentences. We simplify processes. And then we spend time reminiscing with them, because they can tell you all about their past. They can't tell you about their immediate past. Motor skills are a challenge because the brain is where neurons send messages to muscles to move. So what you'll see for folks with Alzheimer's disease and other dementia, they have a lack of coordination and balance. It also affects their ability to chew and swallow. These result in falls. They're at increased risk for falls, and they're also at increased risk for nutritional challenges. They forget to eat, they forget to drink, they become dehydrated, malnourished. They may start a dinner in the microwave, get distracted, 5 minutes later forget that it was lunchtime and never go back. So we go into the home, we make sure that the home is safe, that there are assistive devices in the home, that rugs are picked up off the floor, that there are bars in the bathroom to help them stand up, sit down, that kind of thing. And then we work to make sure that nutritional meals are available to them, whether that's Meal on Wheels or somebody comes in during the meal times and helps them get their needs met. Language becomes a big problem, and folks with dementia have problems finding words. They often use the wrong word. They won't be able to find the appropriate words, so they'll describe something as opposed to tell you what it is. But the most important thing is to remember is that their emotional experience is intact. What does this translate into? It translates into very fragmented conversations. You'll have a problem tracking them, trying to follow what they're trying to say. It would be very instinctive to try to interrupt them, finish their sentences for them. Please do not do that. Focus on their feelings, focus, smile, make sure your tone of voice is warm and friendly. Use simple simple concrete sentences. Don't use abstract words. They will not get it. And we'll talk later about communication. Attention. These folks do not have the ability to filter distractions. You and I can be in a room, there can be other things going on around us. We can focus our attention on the immediate and kind of filter out the background noise. These folks cannot. They lose focus very quickly. What that means is that if you're having a conversation with them and a TV is on or the radio is on or people are walking in and out of the room, they will not be able to focus on what it is that you're trying to tell them. So how you manage that situation is you limit the distractions. You get them in a room that's quiet, there's not a lot of people moving in and out, and you have a conversation with them. They will be able to focus better. And then we simplify the directions that we give them. Perceptions become a problem for folks with Alzheimer's disease and other dementia. The familiar is no longer familiar. Like I said, a rug on the floor will not appear as a rug to them. It may appear as a hole in the floor. So you'll see them stepping over it. Things that they used to know how to use or understand, cell phones, aren't familiar to them anymore. The common things that they grew up with totally lose their meaning. So they have very huge difficulties interpreting directions, how to get around their neighborhood, following directions in their home. They're very impaired. So ways we manage that is we make sure that we take rugs up off the floor, we name objects for people, we never play a 20-question, what is this, what is that with them. And we work really hard to have monitoring devices intact so that we know where they are. We can be alerted if they go someplace and we don't know where they're at. Abstraction, these folks, they have a lack of discernment. Their language is unfiltered. Things that they wouldn't have said before they have Alzheimer's, they can readily say. People that never cussed before, well, you will find them cussing. You will find them talking about things that they've never talked about. Sometimes they're unfiltered in talking about things sexual. So they lack discernment there. They cannot interpret sarcasm. If you are prone to sarcasm, I'm prone to using colloquialisms. People don't understand when you use colloquialisms. Well, that's going to happen with pigs when pigs fly. They're literal thinkers. They're going to wonder what in the heck I'm talking about pigs flying. So you have to be very careful about what you say. No use of slang, concrete sentences. Say exactly what you mean. 2 or 3 words, very simple. And then judgment. This is really the accumulation of problems in all of the other areas. Memory processing. It affects decision making. These folks do not make good decisions. They are vulnerable for all kinds of exploitation and abuse. So we have to limit the options that we give them. We avoid using open-ended questions, and we continue to simplify. So when I say ID a few available options, when it comes time to get dressed in the morning, don't go into their closet and say, what would you like to wear today? Pick out 2 things that are appropriate for the weather and say, would you like this sweater or that sweater? But don't overwhelm them with choices. So here are the characteristics of early stage dementia. I will tell you people in the early stage function very well. They're out and about. They're among you. You may not even know it. They're able to participate in all kinds of activities and dialogue, carry on conversations. They're able to express their needs and share their coping strategies. They have a clear understanding of questions. So this is in the very early stages. You may not even know you're talking to folks who have dementia. Doctors are readily not available or able to diagnose people in the early stage of dementia unless they're well trained. They're able to participate in planning for their future. They want to be engaged. They want to be connected with others, and they're very independent in terms of taking care of themselves. But they are having problems. And this stage can last 2 to 4 years. It is progressive. Here are some things that we learned. You know, what do early stage constituents say they want? They want what we all want. They want to remain active and vital. They want to use non-traditional support services. Many of them want to be in their home with some support. They want to make meaningful contributions and engage in activities that are purposeful. They want to maintain a positive self-image, and they want to connect with others who are experiencing the same thing. Why do I share these things with you? Because when you're developing plans for folks who have Alzheimer's or dementia, and with or without their caregiver, you need to know that they want what everybody wants and be thinking about how do we work to get their goals realized. So part of that planning, again, is a timely and accurate diagnosis. This becomes a double-edged sword. The reality is, and I tell folks, we've kind of got a don't ask, don't tell thing going on, and it has nothing to do with sexual orientation. Physicians rarely, family practice physicians do not have systems set up in their clinics to screen for memory loss. And it's really unfortunate because there is a very effective screening tool available. It takes 3 minutes. It can be done by a paraprofessional, so it doesn't need a nurse or a physician to administer. The receptionist could administer it. The nurse's aide who is rooming in the person can administer it. And it's very predictive of cognitive decline. So physicians don't ask. about dementia or memory challenges. Of those who are experiencing memory challenges, 85% of them will not tell their physician. What we know is that those people who have Alzheimer's disease and other dementia, 50% do not have a diagnosis. And of the 50% that do, only half of them have been told what that diagnosis is. So of those people who are experiencing the signs and symptoms of Alzheimer's, only 25% have a diagnosis. So we want them to get a timely and accurate diagnosis so they can participate in planning. We can make sure their home is safe. They can have a voice in what they're doing. They can get on some of the medications that are more effective. And equally important, we can start working with the caregiver to help them maintain resilience so that the two of them, if they live in their home together, can stay home as long as possible. So what is the intervention? And I will tell you my perspective for you folks. Your primary intervention is to refer them to the Alzheimer's Association. We're developing what we believe is a really collaborative relationship with the AAAs. We are not, at the Alzheimer's Association, we are not experts in the services available in any local community, specifically as it relates to meals and transportation and housing options. You folks are the experts on that. We are the experts on all things dementia, and so we are there to help you out on those kinds of things. We want you to refer folks to us. You can certainly hand them brochure. You can give them access to our 24/7 helpline, but better yet, you send in a soft referral form, and I believe we have that form available in all of the AAAs. It means that you ask your constituent, can we have the Alzheimer's Association give you a call? And then you give us their name, their contact information, you scan that to us, and we will reach out and contact these folks. What we know is if you hand people a brochure or a card with our website or our 1-800 number on it, chances are they will reach out only when they're in crisis, and it will take a lot more work to help them maintain resilience and get them on the path that they need to be. Again, help them get to their physician to secure an accurate diagnosis. That backfires in a lot of cases. A lot of physicians don't know how to diagnose, and we are working with them on that. We need you to address safety needs. Driving is a huge issue. So is being at home and working. Contrary to popular belief, we encourage people not to hide their diagnosis from their employer. There are legal protections in place for people who have a disability, and Alzheimer's disease can be translated into a disability. There are protections in place for people like that through workforce accommodations, short-term disability, long-term disability. The financial implications for Alzheimer's disease are enormous. So if people don't tell their employer what's going on with them, they could be fired for cause, for inability to effectively do their job, and then they're not eligible for any of those other solutions that an employer would be able to offer. So we really encourage people, tell your employer what's going on. We work with employers to help them think through how to support people with Alzheimer's disease. Start addressing caregiver resilience. Let's get some help in the home for that caregiver. Let's get them some education. Let's get them tools on communication, on how to support behavioral challenges, and how to start planning for the future. What we know is that if we do reduce the stress for people with dementia, that cognitive decline can slow down. We also know that if we help optimize health, the most current studies on research would suggest that people who start exercising, who haven't exercised before, who increase their exercise, that is the biggest factor for managing cognitive decline. And studies have shown, even at the University of Iowa, that cognitive decline has reversed and has even slowed down for those folks who get on a exercise regimen. It's also about good nutrition, good emotional, social, and spiritual health. When people feel good, their brain is better. And then we brainstorm strategies to compensate for memory loss, whether that is putting sticky notes on things so people can readily identify pots and pans, telephone, cell phone, whatever it is, to help folks find things. The middle stage, I will tell you, you can take a look at this slide. These folks, they may forget to eat and drink. They can confuse fiction with reality. They can ask the same questions over and over again. You can tell them the answer, and 5 minutes later they'll ask it again because they don't remember what you just told them. Sometimes they can have behavioral challenges. They are really unsafe to stay at home alone, and many of them need help with their basic day-to-day activities, getting dressed, getting bathed, fixing things to eat. I suspect that your interaction with people at this stage will be limited, but I will tell you that a lot of folks, this is really the stage at which most people are getting diagnosed. So you may be in a position to direct people to their physician because you will see these things before they will disclose them. But at this point is really when you need to be interacting with the caregiver on behalf of the person with dementia. This stage lasts 2 to 10 years. There's some conflicting information here. I said the late stage is the longest stage. I've had other things say the middle stage. It's really hard to know. Again, what are your interventions? They're to refer to the Alzheimer's Association, make sure that they're working with their physician on medication management, that their home is being managed for safety issues. People are adopting new communication styles to work with them, and we're surrounding them with natural circles of support. The other thing that you'll start seeing at this point is issues related to pain. A lot of times if changes in behavior, those are related to pain, to medication interactions, and to the inability to communicate effectively. So we always want to make sure that we're keeping pain first and foremost in our mind. And then finally, late stage, you will see that they have limited movement, they're likely incontinent, seldom do they recognize their loved ones, they may not even know their own name. They need an assistance in all things related to daily activities, getting dressed, going to the bathroom, eating, drinking, etc. But they still have feelings, and they're totally dependent on other people for their daily needs. What is it you do there? You make sure, again, they're referred to the Alzheimer's Association. Their dependent needs are being addressed. We're really spending time focusing on the caregiver and their resilience to support them. We're preparing for the appropriate level of care, whether that be hospice, long-term care, or private duty, and we're helping them prepare for death and dying. I'm going to spend just a few minutes here talking about communication because I suspect that this will be one of the biggest challenges that you will face in your role. The first thing that I would suggest to you is always have your radar up for people over age 65 that start experiencing some of these 10 signs. At the boot camp that happened a couple of weeks ago, I gave everybody brochures, even bookmarks that they could post by their desk that reminds them of those 10 signs, and your radar should be up. Now, if these kinds of things are happening to people younger than age 65, know that dementia, Alzheimer's disease, there is a younger onset. We're seeing a higher incidence of that. People who get it earlier in life, in their 40s, 50s, etc., actually that disease progresses pretty quickly. So don't be alarmed if you see this earlier. Have your radar up. But what happens with a person's ability who has dementia to communicate? We've talked about they have difficulty finding the right words. They use familiar words repeatedly because they can't find the other words that they need. They describe familiar objects rather than calling them by name. So if they can't come up with the name of a cell phone, the phone that I carry around with me, or this thing that I carry around with me and use to talk to other people. People start describing their cell phone like that, you should have your radar up. They easily lose their train of thought, easily distracted. They'll start a sentence, they'll not know where they're going. I have that happen to me often sometimes, but I can usually get back to it. We all have those moments, but remember, this affects day-to-day life. They have difficulty organizing words logically. Their sentences don't make sense. They're all jumbled up. If you're experiencing folks that are having these problems, your radar should be up. If folks have a different native language other than English, they may revert to using that native language because that's what's familiar, that's in their long-term memory system. You'll also find them speaking less often. They're well aware that they're having challenges. They'll speak less often because they don't want to be found out. They don't want other people to know that they're having troubles. It's embarrassing, there's a stigma, and so you'll see them pull out of social situations. Oftentimes they rely on gestures more than speaking. I heard a speaker say the first thing you should look for, or that your radar should go up on, if you've got a caregiver and a person who's experiencing cognitive challenges sitting in your office, and you ask the person with dementia a question, and their response is to look at their caregiver to answer that for them, then that should be a radar going up that there's something wrong with that person on a cognitive level. So how do you adapt communication to support these folks? Well, it's really important that you're patient. It takes a while for these folks to process information, and so patience is the best medicine. When I was in nursing school, we were always told on an assessment, orient people to person, place, and time. Those rules don't apply for people with dementia. You don't orient people or correct them. If they say today's Thursday, or what's the date? I just told you that date 2 minutes. I just told you it was Thursday. I just told you it was September 8th. Don't do that. That's the natural inclination. It embarrasses them. It causes them to go silent and to be isolated. Folks with dementia, when you go, hey, today is Thursday, September 8th. My name is Linda. I'm here to see you. I'm your daughter. I'm your son. I'm your husband. Don't play 20 questions. Give them the information up front. Show interest in what they're doing. Don't criticize, avoid correcting them. If you're having a conversation and you need them to make a choice, offer them options. Don't give them 20 options, give them 2 or 3. Encourage unspoken communications, and we've talked about making sure that we don't limit distractions. We focus on feelings. These folks will remember how you made them feel. They may not remember everything you said to them. So what are the best ways to communicate? We've talked about identify yourself. Hi, my name is Linda. I'm with the Alzheimer's Association. I'm pleased to meet you. These folks are people. They wanted to be treated with dignity and respect. Call them by their name. Use short, simple words and sentences. If you are prone to talk in sentences that can go on for a paragraph, you're going to need how to practice how to say things short and sweetly. Speak slowly, not necessarily loudly. These people aren't deaf. They have a problem processing information. So speak slowly, and so that they can process what you're trying to say to them. Ask one question at a time. Don't pamper them with a lot of information. If you're trying to fill out one of your assessment forms, know that it could take a while to do that with a person with dementia. And then when you ask a question, patiently wait for the response. Don't fluster them by trying to answer that for them or jumping in and finishing their sentences. Avoid pronouns. Call people by their names. Don't refer to him or her. Call them by name so that they know what you're talking about. and then avoid quizzing folks. That feels very confrontational. It's very uncomfortable. They won't respond well to that. Maya Angelou is famous for this quoting. They may not remember what you said, but they will remember how you made them feel. So your communication should always be with a smile, with warm, attentive look on your face, and if they know you care, they'll work with you and it'll be easier to do. So what now? What do you do with this information? Well, I've got a couple of things that I wanted to make sure you know. Assess cognitive health regularly. So have this on your radar when you're working with folks, especially folks who are over age 65. Don't hesitate to ask, are you having any problems doing things that you used to be able to do? Are you having any problems with memory? They may or may not admit it, but if you can ask those questions, you may get signals. Know these signs, the 10 signs that we've talked about. Have them readily available. Be on the alert for them. When folks come in that are experiencing these signs, it's not your role to tell them that they have Alzheimer's disease, but it is your role to say that might be something that you'll want to see a physician about. You know that sometimes memory loss can be changed because it's due to, all kinds of things, and sometimes it can't, but you should go see the physician and get that checked out. Refer them to the Alzheimer's Association. That's kind of a sticky wicket if they haven't been diagnosed, but we can support people who are experiencing some of these problems without a diagnosis and start giving them tips and tricks on how to cope with some of the changes they're experiencing. And then I would really encourage you to continue to learn about dementia. I've seen people that have been in the field for 10, 15 years, and they would tell you that it's astounding what they don't know. And so always continue to learn and grow in this field so that you're more aware of not only what the signs are, but how to interact. Personally, what you can do, I would say, be a voice. Speak out, advocate in the public arena, whether it's legislators needing to have Alzheimer's on the radio, on their radar, and in their public policy plans, and even to advocate at the state level on what we need to do to support dementia. I will tell you that recently the Iowa Department of Public Health came out with their top 20 concerns of public health issues for the state of Iowa. Alzheimer's disease wasn't even on it. So very concerning for us. We're not quite sure, but again, opportunity to have a voice about it. The other thing is I would really encourage you to get involved in some of our big signature events. The Walk to End Alzheimer's is actually a week from this Saturday. Form a team, show up, walk with folks, talk with folks, get to understand what this is about. It is a fundraising event, but you don't have to raise money to be there. We would love to have you come and join us. Get involved. There are plenty of opportunities to volunteer and support people with dementia. I would also say be a good neighbor. If you have neighbors that you know are experiencing cognitive challenges related to dementia or Alzheimer's disease, see what you can do to help out. Can you give that caregiver a break so they can run to the grocery store or go get some time for themselves to do whatever it is they need to do? They don't have enough time to be alone, and so if you can be a good neighbor, that would be great. The other thing I would say is know your numbers, know your blood pressure, know your cholesterol, know your weight. Start thinking about how you can get healthy. And so that is what I have to share today. I have handouts. We're going to scan those and send those to you folks. Erin, I know you're there. Do you have any questions? And I'm going to see if I can figure out how to unmute you.
Nope, you just muted her.
Oh, I just muted you, so I'm going to
Click on this right here.
Okay. This?
No, one down below. That one? Yep, now she's unmuted.
So you're unmuted, Erin, if you have questions that you would want to ask. or type.
Erin, let us know if you don't have any questions.
Yeah, we'd hate to cut you off if you're in the middle of typing something.
There's a question mark there.
Question mark where?
Question mark right there.
You want me to click on that?
Mm-hmm. Oh, that's it. I don't know what it is.
Has unanswered questions.
Click it.
Nothing's happening there. Talking, Danica Welch. So, Erin, we're going to assume that you don't have any questions, and I thank you for joining me on this presentation. And if you do, you can reach me at the Alzheimer's Association. Our phone number is 515-440-2722.
And if there was a question and we missed it, we'll email you the answer.
Yes. So thank you very much. Goodbye.